Good morning, good afternoon, good evening. It's a big honor and privilege for me to welcome all the esteemed participants from National Malaria Control Programs, technical partners, researchers, independent experts, CSOs, NGOs, donors, UN agencies, representatives, and of course, our esteemed presenters who are here. I would, on behalf of APMEN Vivex Working Group, co-chair and technical coordinator, Dr. Carolyn Lynch and Dr. Manash, and on my own behalf, would like to warmly welcome all the participants. At the onset, I would like to acknowledge the presence of APMEN Executive Director and team, especially Dr. Fon and his team, who has provided all this technical support needed to get this Tech Talk organized so efficiently and professionally. We are pleased to note that more than 300 participants from 54 countries have registered for the Tech Talk, which indicates that the topic is of concern and interest to many. As we all are aware that Asia Pacific Malaria Elimination Network is a network of almost 21 countries, and we have over 50 partner institutes working under this network. Under this APMEN, we have 3 technical working groups. All are aware that there is a vector control group, surveillance and response group, and VIVAX working group. At APMEN's inaugural meeting in 2009, Plasmodium vivax infections were identified as a common threat to malaria control across the region, and APMEN vivax working group was established to specifically address this issue. Briefly about VIVAX working groups activities. VIVAX working groups activities are focused on addressing key questions defined by the APMEN country partners and are closely aligned with the global and regional elimination strategies. The working groups program responds to the emerging needs of the country as they move through their different stages towards elimination. The VIVAX working group has a cyclical approach to prioritize its activities, starting with identifying key knowledge gaps, building consensus regarding priority areas, generating necessary evidence, and then facilitating, translating findings into policy and practice. Activities are centered around 3 main themes to ensure that the greatest relevance to anti-malarial policy and practice, that is diagnostics, treatment, and surveillance. As we all are aware, the vision of World Health Organization and the global malaria community is a world free of malaria. As part of this vision, the Global Technical Strategy for Malaria 2016-2030 was adopted by the World Health Assembly in May 2015 and revised version was approved in 2021. The strategy has set ambitious global target for reducing global malaria incidence and mortality rates by at least 90% by 2030 and set milestones for measuring progress for 2020 and 2025. However, the recent data and trends indicate that the 2 critical milestones of WHO's global malaria strategy were missed. That is, reducing malaria case incidence and death rates by at least 40% by 2020 as compared to 2015 levels. As such, progress towards malaria-specific target of the Sustainable Development Goal, which calls for ending malaria worldwide by 2030, is also off track. There are several challenges that the countries are facing. The fight against malaria is getting prolonged and in places getting slowed down by several interconnected challenges. These challenges are not unknown to all of us. We know most of them. In countries where both falciparum malaria and vivax are present, the burden of disease due to vivax is difficult to reduce because of the hypnozoid state that is currently undetectable and leads to relapses, thereby contributing to maintaining disease transmission. The current standard of radical treatment requires 7 to 14 days course of medication. Once regarded as a relatively benign infection, Plasmodium vivax is now acknowledged to be an important public health threat capable of causing life-threatening disease complications, debilitating recurrent infections, miscarriage, and chronic infections. The human factors like adherence to treatment is a critical issue that needs to be addressed the best way possible, especially to the radical treatment. Vivax Working Group has started prioritization exercise across the region, during which we have consulted National Malaria Programs, technical partners, and independent experts, researchers, and CSOs. As per the interim report that we have compiled till May, what comes out consistently as one of the highest priority is patient adherence. Of course, newer, shorter treatment regimes will hopefully in future somehow address this. However, primaquine still remains a key tool in the treatment of vivax. Even with shorter courses, we may need to ensure patient adherence. APMEN Vivax Working Group is pleased to organize this tech talk on patient adherence to antimalarial drugs and to share research and operational experiences from our esteemed presenters and speakers today. We hope that the rich experience shared today will benefit our APMEN country partners and show them a way forward. We hope that the deliberations will help us come up with tangible outputs and a way forward. Today, we are very fortunate to have 5 speakers who are working in different parts of the world to speak on patient adherence. They will be making presentations after this introduction, one after the other. And then we will have a discussion, panel discussion with a QA session after their presentation. So with that, I would like to request to show the mechanics of this workshop today is that our audio and video of attendees will be disabled, but we encourage comments in the chat box and question and answer session box. Then, as mentioned earlier, after the 5 presentations, one after the other, we will have panel discussion and QA. You may type in your questions in the QA box. When you ask any questions, and you raise your hand to ask any question, name the speaker and whom you wish to ask the question to, so that they are ready to give you their responses. You can upvote a question by clicking the thumbs up button whenever questions are also put in the chat box or asked. So after that, we will have a session where there will be a quick poll, which has just 3 questions, and all are requested to fill in the poll questionnaire at the end of the session. With that, I would like to introduce our first speaker. So I would like to invite Dr. Anisa Rahmalia, who is the first speaker for the Tech Talk today. Dr. Anisa is a postdoctoral researcher in the Menzies School of Public Health, Australia. and the Institute of Tropical Medicine, Belgium, conducting social science research in malaria, treatment, adherence, and health system strengthening. Today, she will get this Tech Talk started with her presentation on patient and community perception of primaquine adherence in high malaria burden area of Indonesian Papua. So, Dr. Anissa, I give you the floor.
Sorry, I was still muted. Thank you so much, Dr. Karma, and thank you everyone who are attending this Tech Talk. I would like to start with presenting some of the findings of our research in the very high endemic area of Indonesia in the West Papua. Within this presentation, indeed, I will focus on the findings around patient and community perceptions and not so much explaining about the interventions that we did, because I believe other presenters will be talking more in depth about that. This is a little bit of a background and some explanation about the methodology of the research. So in Papua, there's still high malaria endemicity, and this is in this specific part of Indonesian Papua. So, and from past research, we found out that 46% of malaria is vivax. But in a cohort that's hospital-based, but it's not inpatient hospital-based, it's outpatient clinic of the hospital. We found out that patients who are prescribed primaquine, when they have vivax, were only 10% less likely to represent with malaria, to have a recurrence malaria, compared to those who didn't get prescribed primaquine for a vivax, and that was due to drug stock out. So the question about adherence indeed show up, like even when people were prescribed primaquine, did they actually take it? So we conducted a few qualitative studies, and this is the findings of today is done through 2 different studies. Actually, some of them were qualitative study that are tied to drug supervision trial, that's 2017 and 2018. And the other one is tied to like the health system strengthening activity at the local public health centers. And that's between 2019 and 2021. So to give a little bit of a context, this place where I did all the field research is in and around the town of Timika in Mimika Regency, which is in the southern coast of Papua, that with marked by the dot there on Google Map. So the setting actually have various types of inhabitants. There are some indigenous population groups. There are also government-sponsored national migrants who are mostly working in agriculture, or at least that's how they got migrated there to work in agriculture. And it's something that's been going on for a few decades, between the 70s, I think, and all through the 90s. There are also other migrant workers, because the place in Timika is also the nearest town to a huge mining operation that is actually from a multinational company. So there are various health centers as well. There are public clinics, private clinics, but the first health center is actually provided by the mining company when they started operation there. And in a lot of part, they're actually preceded even the government public clinic system. So the other thing that I would like to point out about the setting is, due to the difference of inhabitants, like the various like backgrounds that people have that are now inhabiting the area, there's a huge ethnic diversity. The color wheel on the right hand side is actually just an illustration, and this is from the survey that we did, of the name of ethnic group that people identify with. So it's a very ethnically diverse area. And we also found out that for most people living in Timika, the sense of community is based on ethnic identity rather than area of residence. So not all villages are homogeneous. For certain ethnic groups, there are also areas that are a bit more urbanized where people all live together, but yet they still have this kind of like more ethnic identity to create their sense of community instead of with their neighbors, for example. So to move more on like the perception on malaria from like these various people who live in and around Timika. So most people who live there, particularly those who have been living there for a few years, they do differentiate between types of malaria. They say tertiana, and this mainly refer to vivax malaria and tropica. And these terms, tertiana and tropica, are also the terms that health workers will use when they talk between themselves or to patients. Most people also recognize malaria symptoms and they would self-diagnose. So they go to the health centers to confirm their self-diagnosis based on their symptoms. Also, because it's very highly endemic, a lot of people do get malaria over and over again. And when asked, what do you think is the cause of malaria? Even though most people know that it comes from mosquito, they associate a malaria episode with being tired more than being bitten by a mosquito. And also most people are not aware that malaria drugs, there are malaria drugs that can prevent relapse. I also found out from the certain indigenous population groups, particularly those who are like the traditional landowners of the land that is now become the town of Timika. They're very familiar with people having big belly due to enlarged spleen. They actually call it poro limpa, which limpa means spleen. Poro is actually a local term for belly. So that's what they call it. And I've heard also like some local boys would be taught by their parents that don't hit someone. If you want to hit someone, don't hit them on the belly because they know that it can have grave implications. So these things, yeah, I think it shows that, you know, the people are actually quite familiar and they integrate their understanding of malaria or like the impacts of malaria in their daily lives. About the malaria treatment themselves, at the moment, so DP, dihydroartemisinin piperacin, is a drug that was fairly newly introduced. It started to become the drug of choice, so the first line drug for malaria in 2006. So people really believe in this DP. They call it the blue drugs because, as we can see in the picture, most of the regimens there is in blue tablets. They call them the blue drugs. They know it works, and they associate that as a malaria drug. When people ask, do you know what a malaria drug, they will say it's the blue drug. However, primaquine is generally not perceived as a malaria drug. That's not the first drug that will be mentioned if people are being asked about what do you think, what are you being given when you get malaria? People refer to it as brown drug due to the color as well. Some indigenous population actually call it the spleen drug, obat limpa. And for some people, they actually thought of its function as more like a supplement because sometimes they're being given that, sometimes not. It's not something you need to take until you finish it. They also use a lot of alternative therapy. So a lot of it is in the form of like herbal therapy. The picture in the middle there, that's actually a type of nettle. So for fever, they will put it on their body because it relieves the kind of like sore feeling, I think, because of the itch that they get from the nettle. And on the top right, it's actually a type of leaf that they say they will cook like in a concoction. And so those things are fever alleviating or like symptom alleviating drugs or treatment, that they don't necessarily use that to replace biomedical treatment, but it's complementary to biomedical treatment. They will still go to the health center, but also use this more traditional treatment. About treatment adherence themselves, so because of the nature of malaria medication, they will give the DP and primaquine together with other drugs. A lot of time it would be paracetamol or antacids because of the gastrointestinal symptoms due to malaria or as drug side effects. So I think people are a bit confused sometimes, like which drugs they need to finish and which drugs they can keep for later as well. And DP are always prescribed for malaria because it's the first line drug for all types of malaria. Whereas for primaquine, for malaria falciparum, they get 1, 5X, they get 14. And like for malaria, they get none. So it can vary depending on the malaria diagnosis. So also it's not very consistently seen together with the malaria case. Also, even though they are being explained about drugs and the medication when they were at the health center, if they have a malaria, we did some phone follow-up from research nurses where the nurse would call the patients 3 times during the course of primaquine. So they will call them on day 3, day 6, and then day 13. And this phone call is supposed to be to monitor how are they taking the primaquine. But the nurses gave feedback that sometimes during the phone calls, the patient will ask them again about the drug dose and duration of treatment because they didn't really fully get it when they were at the health center. The other thing that we found out is that it is quite common for people to treat when they have symptoms. Before going to a health center, they will try to treat the symptoms with leftover drugs at home. So it's quite common for them, after coming back from a health center for an episode with some drugs, to keep some of those drugs for later. The other thing is that we see complicates, and this is particularly complicates treatment adherence and also treatment adherence monitoring, is that a lot of the population have high mobility. They only stay in the village during illness, and then as soon as the 3-day malaria fever is gone, then they will go back to their work. It could be down the swampy river on the boat to find fish, or up the mountain to find gold, or some other occupations. So from these findings, I guess we can conclude that in this setting, treatment adherence is not only patient's individual decision, there is a shared kind of like community understanding around treatment adherence, and also the sociocultural logics and practical challenges that underlie patient decisions to adhere or to abandon, underlie patient decisions to adhere or to abandon primaquine treatment. And these patient and community perceptions needed to be taken into account in the intervention to improve and to properly address adherence. So the last slide is really only to kind of like give a little bit of overview of the current implementation study that we are still doing in this setting in Timika. So at the moment, we initiated within the health system strengthening activity that the first dose of malaria drugs, both the DP and the primaquine, is observed at the public health centers. And also that comes along with a more thorough explanation about the drugs. And also community health workers are being utilized for treatment adherence monitoring. However, due to the setup of the population with many ethnic groups, ethnic identity dominates the sense of community, we see that the coverage of community health workers for treatment adherence monitoring is also a bit limited in certain aspects. During the pandemic, we actually do phone calls from the research nurses for treatment adherence monitoring, like what I already mentioned earlier. And right now we are analyzing the data to see whether or not these phone calls have impact on malaria recurrence. So those are the things that is part of my presentation today. I have acknowledgements from all the colleagues, both in the field in Timika and both in Menzies and ITM Antwerp and organizations and everyone that helped us. Thank you very much.
Thank you, Dr. Anissa, for this very interesting research finding and your presentation. Now I would like to invite Dr. Narlada Kantikul. Dr. Narlada is a Senior Technical Officer and Head of Innovation and Research Development Division at the Office of Disease Prevention, Chiang Mai Province. And under the Ministry of Public Health, Thailand. She has a PhD in tropical medicine from Mahidol University and has worked extensively in improving patient adherence to Vivax malaria treatment in northern Thailand. In this presentation, she will be introducing a standard process for needs-based development of support materials for health workers and patients to improve adherence. Dr. Narlada, you have the floor.
Okay, thank you, Dr. Kamar, and good afternoon, everyone. Well, I'm going to talk about a set of tools we have developed, implemented, and evaluated in the northern region in Thailand. All of these tools aim to increase the patient adherence. A set of tools we have developed, implemented, and evaluated in the northern region in Thailand. All of these tools aim to increase the patient adherence to Primaquine 14 days treatment, as well as a key priority for malaria elimination in Thailand. We have implemented since the year 2006 in this Region 1 under the Office of Disease Prevention and Control in Chiang Mai Province. Our office comprising take care of 8 provinces in northern Thailand. For our retrospective study, the year before 2005, there were an average only 24% of Plasmodium vivax completed 14-day course of medication. The crucial factors associated with drug adherence were knowledge about malaria and access to information regarding the disease and its treatment, and lastly, an ignorance for follow-up. Assuming malaria is a burden in Southeast Asia, Plasmodium vivax is a predominant agent as well in ODPC1. Indigenous cases have been happened in men and mainly aged more than 16 years old. As you can see from the map here, there is a cluster of cases along international border areas, especially in Mae Hong Son, Tak, and Kanchanaburi provinces, were ranked to top 3 hotspots. The challenge for completed drug adherence are the remaining cases are located in extremely remote and border areas where the population are mobile and often undertake circular migration to forest area. Before the year 2015, the treatment regimen for chloroquine was complex with 5 doses in first 3 days. It was not so easy to explain to the patient how to take medicine correctly, especially when they came to the clinic in the late afternoon, because the first dose had to be split up between 2 days. And the third challenge is the long course of pymaquine over 14 days, where the first dose is taken together with the first dose of chloroquine. Another challenge is the correct dose of pymaquine need to give by different weight groups, and we have limited available pymaquine dose formulation. A health system related challenge is the qualification of health workers at different levels. In general health system in Thailand, the health workers are qualified to a degree level. However, for malaria, we have a semi-vertical system, and the health workers at a lower level are not qualified to a degree level. Instead, they receive in-service training on malaria specifically. Another challenge is how to gain understanding and concern about malaria treatment costs among the patients. This can improve drug adherence. In this context, and as Thailand progresses toward malaria elimination, we have developed a set of tools aimed at increasing health worker compliance to treatment protocols and increasing patient adherence to the course of pymaquine. This slide shows the malaria standard process at malaria service point in Thailand. The first step starts when the patient comes into the clinic and their data are registered. The malaria test can be made in a slide or in RDT. If positive, GCPD test is required and dry blood spots are collected. For normal G6PD, the patient attend the IEC program and receive medication as in the national guideline with a direct observe for the first dose taking. In case of G6PD deficiency positive, the patient will be transferred to the hospital or consult medical doctor for clinical assessment and treatment. We begin with the thinking that the health worker need a support materials that could assist them talking to the patient about vivac malaria and patient adherence. Based on that, we develop a package of a flip chart, poster, leaflet, and drug bag with treatment instruction label on the back. At the baseline, we conducted a workshop with health workers to identify first, what are needed to be included in the support package. Second, what image, overall presentation, and message resonated with health workers the most. And the third, what are languages that materials need to be utilized in. Then the health worker determined that they need a flip chart, health worker guidelines, and treatment label to help the communication easier with the patient, how to take drug day by day. There was a specific training to use the package and include health facility staff in high-risk area. This slide shows the doses in different weight group in Thailand. Additionally, here is the design for the latest version of transparent plastic bag to put drug for with different dose formulation of pymaquine and chloroquine. We have revised continuously according to the national guideline and available of pymaquine formulation. Here are the drug bag in separate 4 languages, trying to provide instruction how to take drug correctly day by day in different weight groups. The development of a health education package aims to provide comprehension, validity, reliability, and acceptance in both health worker and patient. Here is the outcome after using the package. The cases has significantly decreased. However, last year malaria case increased due to the political conflict and the COVID-19 situation. And almost all malaria cases were Plasmodium vivac, and also drug adherence among them were 83%. The follow-up rate has been increasing also. In the year 2020, there was slightly drop of follow-up rate due to there was a number of mobile migrants. But if we counted only Thai migrants, the follow-up rate was calculated as above 70%. All follow-up patients were confirmed having complete primaquine, and the figure was confirmed when they returned to the clinic with drug bag. Last but not least, in the next step, we start iPhone application that we call Malaria Bot VLI program. This application support health worker to get correct treatment regimen after enter the patient data. And furthermore, we plan using application to improve drug adherence among the malaria patients. In conclusion, we would like to emphasize on the interaction and time spent between the health worker and patients. Spending more time help the patient complete their course. Ultimately, this will advocate malaria elimination here in Thailand. Secondly, we should think about a set of activity for the development of materials, similar to our approach in ODPC1, where materials are co-developed with health workers and patients to ensure we meet their needs. Lastly, the revision of tools is essential. The national treatment guidance change as do health workers and patients want and understand, and we require to move along with those needs. That's all of my presentation. Thank you.
Thank you, Dr. Narlada. Now we have our next speaker, Dr. Kin Mun Mun, is working as the malaria technical advisor of the URC Eliminate Malaria project. She has a long history of working diseases control program of Myanmar, and as a team leader in 1990s, she was also the program manager for elimination of lymphatic filariasis program in 2000. Then again, the program manager of National Malaria Control Program, and she has retired from the Department of Health, Ministry of Health, Myanmar as the director in 2011. Before joining the URC, she worked as a freelance consultant for the Vector-Borne Diseases Control World Health Organization and different international NGOs for about 10 years. Here, she would like to share her experience on improving patient adherence to primaquine through community-based malaria interventions under the URC Defeat Malaria project. Dr. Kin Mun Mun, you have the floor is open for you.
Thank you. Thank you, Dr. Krama. And good afternoon, good day for all the organizers of the APMEN webinar and our chairperson and the co-chair and panelists and the audience from the different countries and the regions. Today, I will present the improving patient adherence to primaquine through community-based malaria interventions. Next slide, please. First of all, I would like to present contextual situation and background of URC team. URC team had received Defeat Malaria project from August 15, 2016 to August 14, 2021. The project covered 36 townships of 4 states and regions: Rakhine State, Tien Dai region, Kayen State, and Sagaing region, covering of 1.6 million population in 2,912 villages. And malaria interventions for those villages and work sites were carried out by the 2,170 integrated community malaria volunteers, so-called ICMVs. In 2021, URC team received new project in the same Defeat malaria area supported by the PMI from 2021 October 1st to 30th September 2026. DOT strategy for primaquine and all anti-malaria drugs has been started since 2018 in the context of case management. Next slide, please. Directly observed therapy. It is used for the adherence or ensuring the full adherence of anti-malarial treatment to obtain the radical cure of the malaria infection. And it includes all the villages supported by the defeat malaria with the network of ICMV. But its successful implementation is dependent on the location of the patient's accessibility by the DOT providers in manageable for number of the positive patients. Next slide, please. For the operationalization of DOT, the inclusion criteria are mainly residential populations of the villages where ICMV is located and accessible by the ICMV. The tasks of ICMV are to observe the patient taking the anti-malarial drugs according to the National Malaria Treatment Guideline, to note down in the DOT form, ensuring full adherence of treatment course according to the parasite species, and to observe the side effects of primaquine. Next slide, please. But we exclude the mobile migrant populations and the patients who are living out of reach of the ICMVs. So our project used the DOT forms according to the parasite species, as the treatment regimens are different. For pre-falciparum malaria, we used artemether-lumefantrine for 3 days course with primaquine 0.75 milligram per kg stat dose for the gametocytocidal purpose. For vivax malaria, we used chloroquine 3 days with the primaquine to 0.25 milligram per kg for 14 days. And for mixed infections, we used artemether-lumefantrine 3 days plus primaquine 14 days, like PV course. Next slide, please. So ICMV has to go a visit to the patient's home at day 1, day 2, day 3 for observing, taking the ACT or chloroquine 3 days course, whether it is taken well or not, directly observe treatment. And then day 4, day 9, and day 14 for observing the taking of primaquine, and then inspecting the appearance of its side effects. If any side effect is seen, taking primaquine must be stopped immediately and the patient must be transferred to the nearest hospital. ICMV has to note down all the evidences. Next slide, please. Regarding the achievement of DOT rule in enrollment and completeness of the PMI funded defeat malaria project, DOT enrollment is during, you can see the number of the patients total tested, and then DOT enrollment and the DOT completeness. So it is decreasing since the 2020. Next slide, please. So when we review the DOT enrollment, completeness, and the proportion of PVIVX and mixed cases among total positive cases, percentage of DOT enrollment was decreasing from 81 to 61%, but DOT completeness was high and static situation between 99 to 100%. Also, proportion of PVIVX and mixed cases were increasing from 50% to nearly 80%. The reasons behind were, according to the criteria, we have excluded the mobile migrant populations and forest goers who are inaccessible by ICMVs. The PVIVX malaria cases were proportionately increasing in our project areas, especially in the Janindai region, as P-falciparum cases were decreasing, even zero in some areas. The PVIVX malaria cases were found in mobile migrant populations and forest goers who are missing for enrollment for DOT, that in turn enhancing incomplete course of PQ, primaquine, and then progressing more relapse cases and onward transmission of P. vivax malaria among them. Next slide, please. So as our project did not use G6PD deficiency testing before treatment with primaquine 14-day course, we take care of PQ side effects in DOT mechanism. From 2018 up to March 2022, among 12,700 cases, we have found only 5 cases of primaquine side effect patients, 2 cases from Cayenne State and 3 cases from the Tanyandai region, 2 cases with pallor, 2 cases with eye color urine, and 1 case with rashes in the skin and swollen lips. All are referred to the hospital, but they were kept under observation after stopping the drugs they recovered. Next slide, please. For improvement of DOT enrollment and preventing the onward transmission of PV cases among the especially mobile migrant populations and forest goers, we have updated our enrollment criteria to include MNPs as much as possible. If we have to do so, ICMV alone cannot handle these people, and we have to expand our field of providers, such as family members, peer group of forest goers, supervisors of the worksite volunteers, and lastly, general practitioners. Also, observation mechanism of PF and PV and other species should be also modified. Different strategies such as phone call and reminding to take drugs or setting alarming system in the phone of the patient or family or peers of the drug taking time for the drug taking time. So I have seen some like this activities in the Indonesia and their presentation. So we also should try the unreached population with this system, and it should be applied based on the phone network availability, and especially in the occurrence of the outbreaks and clustering of the cases, COVID-19 situations and the conflict areas. Next slide, please. To integrate primaquine adherence in routine practices, apart from the ICMVs and mobile malaria workers in our system, because we have the ICMVs for the villages and the mobile malaria workers for the forest camps and also some development project areas. And these mobile malaria workers, they are going around these unreached area, but this is not sufficient for those people alone. So we have to coordinate and collaborate with the private sectors, like the companies, private companies who have the development projects in the forested areas, gold mines, lead mines, many things. So these companies, managers, supervisors, we have to collaborate with them. And also ethnic health organizations who are working in the malarious area, especially we have unreached population from our sites. And also we have to collaborate with the other malaria implementing partners of the same regions. Counseling with the family members and peer group also very important. And we are planning to use this counseling format for these family members and peer group to explain about the benefits and the adherence, the benefit of the adherence and the importance of the adherence of primaquine for their health and their radical cure of malaria. So we can also explain the side effects and to stop the drug taking during the symptoms like that. So, and also we have some the leaflets for the for case management, but it is moved. I have seen glad to see from the Dr. Narada presentations. It is very much appreciated for their IEC materials used for the case management and the DOT. So we have to use some special format IEC material for the DOTs also, it is necessary. So I think we have to use also the coordinate with the general practitioners who are also working with the intimate relation with the patients of fever, and then these people can coordinate with us, and then we can share their information, and also they can share us the name of the patients, and then how we have to support them for the dots. So these, I think this is my last slide, and then next slide, please. So I would like to conclude my presentation here, and then my sincere thanks goes to the APMEN organizers who invite me, and also Dr. Asin and the headquarter team of URC, and Dr. May and Dr. Jor of URC team, and all my field teams from the URC Pharma. Without their support, I cannot present this presentation. Thank you very much for your kind attention.
Dr. Karma, you're muted.
Yeah. Okay. Thank you, Dr. Munmut, for your presentation. Now I would like to invite Dr. Manash. Dr. Manash is a public health social scientist, and at present he works as the technical coordinator of APMEN Vivac's working group. Today he will be highlighting different ways to measure patient adherence to anti-malarial drugs. So Dr. Manash, please. The floor is yours now.
I'd also like to thank all our panel speakers for accepting our invitation and coming here today and talking about their work. We heard from Dr. Anisa that patient adherence is not just a personal decision, but that is actually shaped by the social culture environment that people are in. So actually, we also need to consider the community perceptions before designing any interventions. And then we heard from Dr. Nalata that she has developed a package of interventions that has worked in Northern Thailand that not only considers the patients, but also addresses the healthcare workers and helps them to improve their counseling and their efforts to help patients increase adherence. And then we heard from Dr. Monmon that how DOTS still remains the gold standard for patient adherence, and how CSOs can play a role in actually following up with the patients and helping patients adhere to the treatment also through other community-based interventions. So now I'd like to touch on something that is often overlooked and undiscussed when you talk about patient adherence. It's actually on how to measure patient adherence. And patient adherence has been a very close topic for me because having explored vaccine hesitancy during my PhD, I find some overlap between why people don't take vaccines as to why people also don't adhere to the full treatment regimen for antimalarials. And again, it's not just a personal decision, but it's the social cultural factors that play into role that often conflict with the personal knowledge and experience. And that's something that our previous speakers have also touched upon. And on patient adherence, we are coming out with an evidence brief that might be available shortly in our APMEN website. And this work has also led us to embark on a scoping review that will be completed soon. And but just to let you know what we've found till now and how to measure patient adherence, as there is still no gold standard. There is no one way to measure patient adherence. But before we go to that, let's take a look at what actually is patient adherence. From the WHO, we know that medication adherence is the extent of agreement of the patient's behavior with what they are recommended by the healthcare worker. But from a social science point of view, we can see that it is a continuous decision-making, wherein the patient evaluates and reevaluates the course of their illness along and compare them with the perceived risks and benefits of the medication. And this is where the social cultural factors, the norms, come into play, and they have their say for what they decide to do. But when we break down adherence into different stages, we can see that there's an ABC model, which says that there are 3 different times that people can be non-adherent to medication. A, that they don't start the medication at all, which is less likely for malaria because they have the symptoms, they want to get better with the symptoms. B, in the implementation phase, as they're taking the medication. Once they get better, they might forget to take medication. And this is where they either delay or omit to take some medication, some doses. And then finally, if they continue together, either because they have certain side effects of the medication or they believe that the medication doesn't work for them. And so these are 3 different stages where people can be non-adherent. And maybe this is useful to know because the interventions can be designed that way as to tackle the real source of non-adherence. But let's go into how to measure non-adherence, because the interventions that we have designed, somehow we don't get to measure it effectively as such. So when we looked at the literature, there are different ways to measure adherence, and we can broadly classify them into 2 broad groups. One that measures the process of taking the medication, and one that actually looks at the outcomes of what happens after people take the medication. So let's first do a deep dive on the process indicators. It measures the process of people taking the medication, and it can be either direct, as in the directly observed therapy, like Dr. Monmon said. It's not just an intervention, but also actually you can measure and actually track people taking the medication or not. It's a direct way of doing that. And there are indirect ways of tracking the process of measuring people either take medication or not. The most often used is patient self-report. There are also validated scales and questionnaires that we'll talk about a little bit. And then there are pill counts and iteratory monitoring. So there are different ways to actually measure the process. When you go into the directly observed therapy, this is where a healthcare provider actually monitors every dose of patient's treatment. And this is the most accurate because it's happening directly in front of them. But there are certain disadvantages to this way of measuring, because some patients can hide pills in the mouth and then discard them just to throw off the healthcare workers. And I think this becomes really impractical in routine use, especially for very high burden cases or very high burden settings where there are lots of people to follow up. So this might be slightly not practical for those settings, but in elimination settings, I think this is the way to measure, a wonderful way to measure patient adherence. And there's also digital observed therapy, where in settings where people have access to videos and mobiles, they can actually be tracked for taking medication through a mobile device, through a video, so that the healthcare workers can actually see the patients taking the medication and then observe them. And moving on to another form of indirect measurement, this patient self-report. I think this requires not much explanation, but this is where actually we ask the patients about their treatment and whether they've taken the drug or completed or not. This is very simple, inexpensive, and useful in clinical settings. But this is often, there are some limitations to this technique because this is highly subjective. People can forget the dosing that they took or the real medication that they have taken. And people have a tendency to provide answers that we're looking for. And that's why there is a high possibility of social desirability bias happening with this technique. So, and just to as an improvement on patient self-report, we have validated scales or patient questionnaires, wherein there's a list of questions to ask the patient that can help healthcare workers to predict who can become non-adherent in the future. And this can be, this has been tested in many settings through different questionnaires. And it's, even in malaria, there are a few validated scales that have been used in certain research settings. They found it valid and reliable. And it's easy for healthcare workers because they can actually use this as the point of care. And if they find somebody who can become non-adherent, they can provide timely feedback and then address those underlying causes. So this can help healthcare workers a lot. But again, people can have a recall bias. People can forget what the medication they took, and they can answer differently. There's also, again, a possibility for social desirability bias when we use the scales. But just to give you a very brief insight into different types of questions that might be useful in our context for malaria, there's something called as Moresky Medication Adherence Scale, also known as MMAS. It's a 8-item self-report measurement of taking the medication. I don't want to go into too much details into the items because these are also available in our evidence brief and can be found online. But the takeaway that I want to focus on is that through these valid questionnaires, we'll have a category of, we can categorize people into 3 levels of high adherence, medium adherence, or low adherence, so that we can know exactly if certain kind of patients might fall off the medication and may not adhere, so we can actually just address them specifically. And there's also a shorter form of MAS, it's called MMS5. So there are only a few questions, 5 questions in this one, shorter version. This might be useful in settings where there isn't much time to talk with the patient. And this has been used in Brazil to effectively estimate the adherence rates. It uses a 6-point Likert scale, but these details we have kept these details in the evidence brief, so you can take a look at that. And there's another one called Medication Adherence Report Scale, MARS. This is a 5-item scale. Similarly, there's a cutoff point. So the idea is that we will have categorization of patients into different categories of adherence, and then go on forward like that. Among the adherence scales, one of them is actually developed in a developing country of Pakistan. So they've actually also incorporated an adherence cost related non-adherence factor, so that our low resource settings are also reflected in these kind of adherence scales. And this can be worth your consideration if you think that cost can be an issue for medication non-adherence. Again, they'll have scores and categorize patients into different categories. But the takeaway message is that we can use those validated questionnaires as a part of our routine practices to not only look at who can become adherent, but also as a tool for monitoring evaluation and to see if our interventions are actually working or not. And then the other measurement that is often used is the pill counts, where we count the number of doses remaining in a medication container, such as a blister pack. And the idea being that we just count how many doses are supposed to remain as to how many actually are there. And the advantage is that this is manual, direct. This can be done during the visits to the health facility, or can also be done at the home visits. It is very objective, quantifiable, and easy to perform. But again, this can also be limited by some potential biases, as patients can actually just alter the data by just opening the blister but not actually taking the medication. So this is another way of measuring medication adherence. And then there's another way is electronic monitoring, wherein we'll have electronic microchips in the opening of the pill boxes or blister packs. The assumption being that once it is opened, that means people take the medication. And this has been used in different research settings. It has been found to have less recall bias and less social desirability bias. However, it is proved to be a little bit expensive, and it requires return visits and slightly technical know-how to download the data from the blister packs. Now, let's look at the other set of indicators, which look at the outcome of taking medication. So once people take medication, there will be some kind of interaction in the body, and there can be pharmacological outcomes that can be measured. For example, concentration of drug or metabolites in blood or urine, or methylglobin concentration for PQ. So these are two biological assays that can be measured to know if the patient has the adequate level of the concentrations as we would expect after taking the medication or not. Although this is more suitable for research settings, it may not be as applicable in routine programmatic practices, but this is just there, which you might consider for a small set of people doing your malaria indicator survey or some other surveys that you might want to take. So this is another way to actually triangulate information from other set of measurement techniques. So in a way, this is just an overview of available measurement techniques for patient adherence. And as I would like to urge the audience to maybe type in your chat box as to what you used for measuring patient adherence in your research or in routine practice, and what you think would be the best way to measure adherence, and how we can incorporate in routine practice. For a start, that we think that at the point of care, validated scales can be used to predict non-adherence behavior. And also we can use this as a part of semi or supervised treatment, like in DOT, and then as part of monitoring evaluation, and probably preferably combine 2 or more measurement strategies so that there's the data that we get is more reflective of the true reality. So having said that, I would like to end my presentation and look forward to the discussions in chat box and question Q&A. And I'll give the floor back to Dr. Karma. Thank you.
Thank you, Dr. Manas, for your brief, comprehensive presentation. I would like to remind our presenters that there are some questions in the chat box. Kindly answer them, and we will have question answer session later after the presentations, during which you can address some of the more pressing and recurrent questions that you are getting. So now we have our last presenter, Dr. Lindis Winnie. He's a medical officer and in charge of the case management unit of the National Vector-Borne Disease Control Division, Ministry of Health, Solomon Islands. He will be reflecting on improving adherence and integrating the intervention into routine practice from the perspectives of National Malaria Program. So Dr. Lindis, you have the floor.
Thank you, Chair. I think I'll just wait for the screen to be shared from organizers. Okay, I'll be doing just a short presentation, and it shouldn't take long, but this would be a presentation based on how we have looked at chloroquine, primaquine adherence in Solomon Islands. Next slide, please. Yeah, just a background, quick background. Solomon Islands has a population of about 700,000 people. And just recently, our API was just above 110 per 1,000 population. And out of this, currently now, Plasmodium vivax accounts for about 67% of the total infections. Next slide. Which basically equates to about 52,000 actual cases of Plasmodium vivax mono infections. G6PD prevalence in the country is about 23%. That's just from data from Rosalind House. So in the country, one of the main things that is a challenge to us is the actual prevalence across the country. We haven't determined that yet. So it's taken out from just a few surveys that we've done. So that G6PD prevalence has become a challenge for us as well. Next slide. Next slide, please. Okay, so this is how I decided to look at the effectiveness of primaquine treatment in Solomon Islands. If we look at these 6 factors, from efficacy down to effectiveness, I've just tried to give some sort of figures to demonstrate this. And the first thing with efficacy in Solomon Islands, first of all, we are using the lower dose for 14 days, 0.25 milligrams per kg for 14 days, noting that, we have predominantly the Chisholm strain for Plasmodium vivax. Then you have all these other factors that affect the effectiveness, of which patient adherence is one of them as well. Accessibility was based on stockouts. So an estimate was, it's not 60% of stockouts, but most times we have 60% of supplies in our pipeline. Diagnostic coverage to determine the diagnosis of malaria is about 76% coverage. This is both microscopy and RDTs. Then we have this this indicator in our system that looked at patient treated according to their treatment guidelines. And the data from 2020 was 71%, but recently, just 2021, we've started to look at that data now. And it's gone down to about 50.4, just around 50%. As you all know, that probably could be whether it's actual the provider compliance or it's due to the stockouts because of the recent difficulties in providing commodities out to the provinces in Solomon Islands. What we are talking about now is patient adherence, which, if from the previous talk, there are ways that we can measure that, but in Solomon Islands, we haven't started in measuring patient adherence in any form or formal way to measure that. So we don't have an exact figure for that, except for measuring the actual prescription practices. So patient adherence is actually still an issue for us for the formal measurement of adherence to treatment. Next slide, please. Okay, so if we have a look at some of these the issues with primaquine adherence in Solomon Islands, most of the things I call them external factors, and I think these external factors, which mostly are systems, it's mostly distribution, availability of drugs out in the facilities that really need them, is one of the biggest nut we're trying to crack in Solomon Islands. We're in a system that has been quite weak over the past years. So in order to improve adherence to primaquine treatment, we have to improve these delivery systems. We have to improve the prescription practices. And I note that from the previous presenters as well, there were very innovative ways that we can adopt in the Solomons to improve patient adherence in our systems. if we can go on to the next slide. Okay, so I've listed down here some things that I've sort of taken away from the previous presentations that would fit into what I've written down. And one of the things that was from the other presenters from Thailand, Myanmar, and Indonesia was the use of communities, community and societal organizations to actually help in adherence and monitoring of primaquine usage. So in Solomon Islands, there's a policy that they have tried to adopt now, which is called a healthy village setting, which looks at putting health workers, possibly when it comes into fruition, out into the villages who can do these kind of things like dots, monitoring patients. That is one of the things that we see might be beneficial once that gets on board. And then we have what they call the role delineation policy, which now is trying to streamline health facilities better than what we have now. So hopefully with these policy at the ministry level, we can improve the compliance and adherence to primaquine in the country. But as a program, we see that probably the biggest problem that we have is G6PD diagnosis for deficiency screening. And we have just recently gotten the SD biosensor into the country, and just a few weeks ago, we've had it approved for use. So we are hoping that this issue that we always say that there's always health workers are reluctant to prescribe primaquine, although we're using the 0.25 milligram dose. Health workers in our setting are still reluctant to do that, probably rightly so. But now with the SD biosensor, we hope that we can actually take that issue away. And if we do make sure that the rollout of SD biosensors is optimized, then we would look at, remember that I said that we're still using the 0.25 milligrams per kg body weight for primaquine. We're hoping to increase that to 0.5 milligrams per kg in the next revisions of our treatment guidelines. Also, I think from the other talks as well, there was what we see is as there was different sort of treatment options for the different outcomes of the G6PD testing, which we hope that we can streamline those in terms of whether for females or intermediate and deficient patients. We will certainly learn from other countries who have already started the program and see if we can adapt that into our country. So for Solomon Islands, I think our main issue at the moment, like probably if you remember from what I said right in the beginning, we have just above 50,000 cases, which probably in the bigger sense of things might not be enough. But for a country with a small population, with many challenges in terms of logistics and systems within the country itself, I think that it is still a challenge for us to optimize our systems. And I think one of the things that is very important that was actually highlighted in this tech talk is the use of communities and the actual patients who are taking the drugs by increasing their knowledge of why they are taking drugs. Because in Solomon Islands, I from the first talk, people are aware. They call Plasmodium vivax infection, 14-day malaria, because they know historically that they had to take 14 days of primaquine. So in terms of differentiating vivax malaria, I think that knowledge is here. It's more optimizing the systems, making sure the systems work together. All the strategies are integrated into a cohesive system that we can use. Next slide. Yeah, so I decided to put this slide up because taking into account, where we are, how things have gone up in terms of malaria incidence in the last few years. It's actually increased from the lowest point we went to in around 2015. But there was some modeling done by Lisa White of the, I think, Oxford and Moru unit with her other colleagues. They said that, if we optimize and use future innovations, which I think for Solomon Islands is more what the other countries in Asia Pacific are doing, is the involvement of communities, including, to some extent, mass drug administration, probably improving vector control through IRS and LLIMs. Then they model that probably we can achieve elimination by 2030 with a host of other Asia Pacific countries. So our outlook is that with the lessons we've learned from other countries, I think, although we've sort of painted a bleak picture, but we think we can achieve falciparum elimination probably first, and then vivax elimination in the not too distant future. Thank you. I think that's basically what I have for just to start the discussions.
Dr. Lindis, it's over. Okay. Thank you to all the speakers for your presentation, and very useful information were shared during your presentation. Now, we would like to go for a few questions to be answered by the panelists. I think the first question will be for Dr. Anissa. Dr. Anissa, there's a question from Dr. Joshi, Dr. Joshi Provin, related to PNG. He says that primaquine and malaria issue has been known for a long time. Even today, PQ is not known as anti-relapse and gametocidal activities. Many NGOs worked and working, but problems remain same. Why does this remain the same? This is probably the question to Dr. Anissa.
Okay, thank you so much, Dr. Karma, and thank you, Dr. Joshi Pravin, for the question. It is like, I think every one of us probably share that frustration with, well, it feels like we've done something, but the problem remains the same. And I also heard this voiced by one of the health workers actually very recently in Papua, that she was like, I feel like we've done everything we could. Why is, people are still not taking the drugs? So I think when it comes to and how people perceive it, well, it's obviously as well that there's, I think, a gap of understanding between what we know and what we explain to the patients and how they receive it. So sometimes they don't necessarily, take what we as health workers say at face value, they integrate that within their, like previous experience, previous understanding, their daily life. And I think probably that part that we've done enough of, but also like what Dr. Lindis just mentioned in his presentation, that there are actually other also external issues related to creating this problem. There's probably some stock out issues, but there could also be just the case that the prescriber is not necessarily the one who understands. And that is like the challenge in a lot of primary care centers, particularly in more, like challenged area in all countries. I believe that most of the time the prescriber are not actually someone who is knowledgeable, or probably not even supposed to give prescription. Like in Indonesia, actually nurses are not supposed to give prescriptions, but sometimes in certain places, the doctor is not available, or the doctor isn't even there every day, like in some health centers in Papua. So in the end, the nurses are tasked to do it, but not with a very clear protocol, or they're not used to following the clear protocol, or they haven't even seen it. So, like I think there are some health system strengthening that we also need to do, like from the more structural aspect, in order to increase, like education for people's understanding, and also to improve adherence.
Thank you, Dr. Anissa. Dr. Anissa, there's another one question from Dr. Nurul Nazaruddin to you, and also to Dr. Narlada. This is a common question. What are the drivers to enable and prevent patient adherence?
I think from the patient perspective, the drivers are related to, well, one's obviously, the first thing is really what they understand about adherence. I feel like in my setting where I work in Papua, it's not that they don't want to take malaria drugs, but it's really because they don't perceive the primaquine as a malaria drug. So when they say, yeah, I finished my malaria drugs, it's the DP, the blue drugs that they're referring to. But also there are other constraints. For example, people mobility. So 14 days is obviously a very long period of time relative to how many days people are sick of malaria. And after they're not sick again, people are traveling for work, people do their daily activities, they return to the gardens, they return to like the mountains, the river, wherever they need to go. And I think in a way that kind of like can hinder patient adherence, because when they're out in the field all day, they told us, well, even if the health center said take it at like this time of the day, every single day, they're like, yeah, I don't have drink at the time, I don't bring the medication with me. So there are a lot of different constraints, and these are obviously not something that can be generalized. I guess like in each context, there needs to be an understanding between the like constant dialogue between the health worker and the patient, I think, to reach an understanding of how that can be done and in any given situation. Dr. Narlada, probably you have something to add.
If Dr. Narlada has anything to add. Let's go to the next question. There's one more question on to Dr. Kin Monmon.
Yeah.
Dr. Ankana says that your presentation is good. I'm interested in G6PD due to patient may stop taking primaquine and may think that the drug make them more sick, lead to wrong attitude. Do you have an answer to how this could be?
Yeah, actually, I have
addressed?
answered already in the Q&A box. Yeah, it is maybe it may be true. Patient may afraid of knowing the side effects, and he or she may not take afraid of taking the drugs. But it is actually needed for us to counseling and make understanding the benefit and the pros and cons. Yeah, they can have a radical cure, and they may not have the repeated attacks of fever, and also they may avoid they may have more earning because so something like that. We have to explain thoroughly. So we have to develop a counseling format for these patients and thorough counseling for this, especially for the people who have not to be tested by G6PD deficiency. It is quite essential for them to explain. That is, I have already answered like that. Thank you.
Thank you, Dr. Munmon. For Dr. Manash, you have one question from Dr. Christine. Which scale do you feel would be the most appropriate in the malaria elimination context?
Thank you, Dr. Karma. I think I also got one question from Nuan as she was asking which of these scales have a better validity, or So I guess the caveat is that these scales were actually not made for malaria. These were made for chronic diseases. We might think that adherence is an issue only for malaria, but actually it's a bigger issue that all the diseases, even chronic diseases, suffer from lack of patient adherence. And pooled analysis have shown that the adherence to chronic disease is not just 50% above that. So this is a bigger issue, and we are part of it. And all those scales have been actually developed for those chronic diseases. So I guess all those the scales would have to be adapted, translated to our context, and then measured to see which one would work better in our settings. But bear in mind that Kwan et al. Have done a systematic review on these scales, and they found that only a few questionnaires actually have moderate evidence of being helpful to measure non-adherence. And the ones that I present today have passed that bar, so they are slightly more reliable than others. But to Nuan's point, that I think what research in Pakistan shows that the General Medication Adherence Scale, GMAS, has slightly better inter-rate reliability, slightly higher cronbach's alpha than the Urdu version of MMAS. So that might just be a specific answer to Nguyen, but that also depends on what we do for our context, right? So, and to answer to Dr. Bannock's question as to what would be the best for malaria, I think that would still require a bit of experimenting and researching, and to find out what questions need to be tweaked so that it's better replicated in or better applicable for malaria, because those questions are actually detected for chronic diseases. And there has been some research in Indonesia where they've used MMAS. These are initial results coming up, but I think they'll require slightly more concerted effort to see what questionnaire is better for malaria. And just to let you know that maybe all these things that we talked about today, from measuring patient community perceptions as a critical part of adherence, and also looking at different interventions and measuring patient adherence, this can be made a part of routine practices if we start thinking, because what gets measured gets improved, right? So I think if we can incorporate somehow into our routine practices, and some of the ways could be as simple as having this in our case management, or having this as a part of our healthcare worker training, so that the healthcare workers are trained on that. I think Dr. Nalada pointed out that maybe we can elaborate a little bit more on that, how healthcare workers can be oriented better. Yeah, I think she touched on this on her presentation, but I think I'll request Dr. Nalada to say how healthcare workers can be, useful and very helpful in getting this intervention or getting this measurement into routine practices. So maybe I'll direct the question to Dr. Nalada then. And Dr. Nalada, I think you are muted, so yeah, no. Thank you. We can hear you, Dr. Nalada.
Again, please, Dr.
Oh,
Manal.
sorry. So I was just letting the audience know that the practice that you worked with healthcare workers and how that has come into routine practices. Maybe our audience would benefit greatly as to how we can readily, incorporate some of the things that we talked about in routine practices in other settings as well. So.
ยังไงนะเจี๊ยบพี่ไม่เข้าใจยังไงนะพี่ไม่เข้าใจเขาพูดว่าไงนะฟังแล้วก็ยังงง
Maybe I spoke a little bit too much then.
A little bit slowly.
Maybe you can give us a bit of your experience on how incorporating healthcare worker training or those interventions for packages for healthcare worker. How was your experience on that one?
Oh, okay. Yes. Before we know that the problem of the patient, what is the problem of the patient, that they don't understand the message that we are convey from the health worker. So that might be look back at the health worker when they talk to the patient. It might be easier and friendly with the patient and make sure that they understand what the health worker say, want the patient to do, followed by taken medication course. So we use like a image that you see on my presentation, that we have different two type of medication, and you see, and we try to convey the way to take the medication on time. And if they start, even they have to take medication day by day. If they start with in the morning, and the next day should be in the morning every day until complete their medication, that they understand. After they take which dose they taken, they will cross on the picture that already taken. That's why they come back with their label back and let us know which day that they forgot. And sometimes they forgot just only, maybe they forgot to take in the morning, but they can take in after lunch or in the evening, but in the same day, they can complete their medication on in 14 days or yes.
Yeah, thank you, Dr. Nalada. I think by having better patient counseling, that if we can improve on patient counseling by elaborating a bit of time on that, I think Anisha would definitely chip in here with her work in Malaria Corners, where they have dedicated staff just for counseling patients, and that has worked wonders in high burden settings where people get attention, and they not only learn, but they feel that they are empowered so that they can go back and then follow the instructions, right, Anisha? Yeah.
Thank you.
Thank you, Dr.
Okay, then thank you to all the panelists for their answers to few questions. I think there are few more questions, but then I think we will give you the answers at a later period, because it's time for us to now close the session. So I think all the presentations have given us a lot of insights into various aspects of patient adherence and the health system aspects, the patient's perspective and community perspective, and that we need to take into consideration not just the health system's point of view, but the provider's point of view, but even the community and the patient's perspective, taking into consideration there are several unreached population, mobile population that we need to make them understand if we have to eliminate malaria. I think there are a lot of things to do. Most of the presentations have been able to show us how things were made possible and how could it be used in certain other malaria programs can make use of those findings and experiences. And now that come to the end of this session, I think we are very grateful to all the participants who have remained with us till the end of this session. And we are extremely grateful to our panelists who have taken out their time to give us this presentations and prepare for this prepare presentations in this last few weeks. We are also very and grateful to the APMEN, Dr. Phone and his team who has been working continuously for the last few weeks to make this happen. And without the support of all the participants, I think it wouldn't have been possible to make it more lively. Things have really come up in a big way in patient adherence area, and we are trying to further address this through the Vivax working group, especially in the area of Plasmodium vivax, adherence to Plasmodium vivax treatment, which is going to be one of the major activities to achieve if we have to really eliminate malaria till 2030 target and achieve the 2030 target. So from the co-chair, Dr. Caroline and Dr. Manash and Dr. Phone, Dr. Amita Chebi, all of us from the APMEN and Vivax working group, we would like to thank everyone. There will be a poll of 3 questions. I think Dr. Phone is going to put it on the screen now. You can see that there is a poll, so you can run through this poll, and after that we will end. Thank you for your participation.